Hello, Cam followers. It's lovely to see you. I am very pleased, very pleased to have the lovely Dr. Tamara Grubb come back. She's been on Cam before, so please do go onto our YouTube channel and go and dig out that live because it is just, you'll feel very warm and cuddly inside. She's also done brilliant stuff for us for the big walk last year, and I'm sure I'm going to persuade her to do a little soundbite again for this year. So that is around the corner. But before we start, I want to say a massive thank you to our sponsor. We would not be here without Big Barker. They have stepped in and they are absolutely game-changing 2020-22 for us. The reason that we're really happy to be associated with Big Barker is that they have put their money where their mouth is, and they have done a clinical trial, a pilot study, looking at the benefits of having good quality bedding. And their pilot study that was run by the University of Pennsylvania had positive results. And this is really important because I think a lot of you guys don't realize that when you go to buy a product, much of it and much of what they say is unregulated. So orthopedic is unregulated. Having claims that it improves pain, etc., unregulated. So this company, and I'm very proud to be associated with them, have actually done studies to show that their product is of good quality. Have you had much to do with Big Barker?
This is all new to me. I'm learning from you, but I'm
they're looking for people. I'm going to send them your way. They're really looking for vets at the moment, and you will get a lovely bed in return for you just saying, yeah, I'd happily try one.
Well, and that big dog bed, it looked like I would easily fit on that, so I could just keep it for myself. I mean, I do have an old Labrador that could utilize that bed, but hey.
Oh my God. It's amazing. It's amazing. I sleep on mine. So what we're going to be talking about today is the emotional impact of pain and the impact of emotions on pain. And it's a really, it's just, I love this topic because there's so much we can do with it tonight with your dog, tomorrow morning with your dog. Once you start getting your head around it, you realize that there is so much lovely stuff that you can do with your dog that could actually impact their pain experience. And Cam is all about trying to make sure that you guys have the tools to do the best job you can now, and affordable and available. This is it. So I'm going to start off with a quote, and then we're going to lead from there. So just so you bear with, guys. Pain is actually defined as an unpleasant subjective experience with a sensory and an emotional component. Psychological health comorbidities in humans, especially anxiety, depression, and anger, are highly prevalent in people with chronic pain. What do you think about that then?
I think it is a great description, and that is the definition, though, that made a lot of people say way back in the early days, right, that animals didn't feel pain because they didn't have an emotional response. So people actually use that definition against our patients, saying, well, they don't have emotions, so they can't have an emotional response. And now you and I and probably everybody listening to us knows that that's so wrong. And I think also to look at what we mean by emotions, because a lot of people say, my dog is happy when I have a birthday party for him, and we know that they look happy, they jump up and down and run around, but we can't really measure happiness, right? That's an anthropomorphism. But there are emotions like pain and fear. Those are also emotions, and we can measure those and see the results of those, like learned behavior from something that's painful. And so finally, I think we're coming around to saying, and I do think my dog is happy with the birthday party, but again, can't prove that one. But yeah, it's interesting that we've come now, finally, a long way. And now we're not using that definition against animals, but we're saying, no, wait a minute, they do feel pain and there are emotions associated with it.
Yeah. So I did a little bit of digging today, and it's actually really hard to kind of like clarify what we mean by emotion, and it really overlaps with pain, because pain is a subjective experience that we express. So does pain itself start falling into an emotion? And I read this, it's hardcore. Most perspectives hold that an emotional experience are from the outcomes of interactions between the somatovisceral patterns mediated by the functionality of the peripheral nervous system, as well as our cognitive processing, e.g. memory and attention, as well as our metacognitive attributions, appraisals and evaluations, mediated by our central nervous system. And I was getting in this going, hell, man, this is heavy stuff. But can you kind of like, how can we summarize? Because people throw the word emotion around all the time, but what are we trying to infer about a negative emotional experience so that when we talk about pain, people know what we're kind of talking about?
Sure, I'll go first, but I want your input too, because you're right, that thing is so complex, but it's good to see that it's that complex. So this isn't an easy thing, and there's no way to separate out pain and behavior in most of our patients, and then pain, behavior, and emotion. It's so intertwined. And there's some really cool studies in human medicine that show that the parts of the brain, so they're functional imaging studies, parts of the brain that light up in a patient that they created an anxiety situation are the same parts of the brain that light up for pain. So there's this crossover. Yeah. And so I don't know how to divide it out. It just all goes together, and we say, okay, pain causes behavioral changes. And then those behavioral manifestation, we see the behavior that was the manifestation of the pain. But the fear, anxiety fits in there too. I don't know how to divide it up. I don't know how to simplify it.
Because to me, when I was trying to distill it down in a very logical way to talk about it, right, let's first define what an emotion is, and then let's define what pain is.
Yeah.
And then we'll be able to just show you that pain drives an emotional change. And I was like, oh, this is messy. And exactly the same. It's because there is so much happening in these same brain regions. As you said, the areas that control your fear, your depression, your anxiety are the same areas that are lighting up when you are in pain. And so it makes sense that there's a real merge there. Let's just read. Well, no, actually, I'm going to stop. The other thing that drives me crazy is so blinking logical. So to the vets from many years ago and all the social scientists that were like, no, they don't have emotions. No. There is no way that you can't be in a negative emotional state when you're in pain.
Right.
Does it make any, and to me, obviously, if somebody improves my mood while I'm in pain, my pain will diminish. It's so logical. So I use this example all the time when I'm teaching. You're on your way to vet school, because I teach vet students quite a lot. You're on your way to vet school, and the car breaks down, and it's raining. And as you walk into vet school, soaking wet, you stub your toe. So you're in a negative emotional state, and you stub your toe really hard against the door frame. You're going to be, oh, that really hurts. Counter that. You're on the way to vet school, the sun is shining, your car drives like a dream. You get out of the car in the blazing sunshine, you pop into the newsagent to get a can of Red Bull, and you win the lottery, £10,000 richer. You walk in, you stub the toe, you don't care. It's irrelevant.
Right.
And how different. But when you actually talk about it really frankly like that, it's so logical. And then when we take it into the academic side, we start making it really complicated. Is that fair to say?
I love it. That definition. I was like, I don't know how to do it. You just solved the whole problem with a Red Bull. So I love the way you described it. You're absolutely right.
Yeah, but I can teach that in that way because it's so logical and so obvious and it's so everyday. But as soon as I started going into the academic side of things, I found myself getting really twisted and caught up. And I wonder if sometimes when we take things into a more academic kind of literal manner, we make it a bit intimidating and a bit confusing. And we are allowed in our situation to go, right, my lovely client, Mrs. Smith, with your lovely dog Clover, the big Labrador. Do you know what? You and me know if you're in pain, but someone turned up with a box of chocolates and gave you a big hug, that pain would diminish for that period of time. Yeah, it would. Well, why don't we do that with your dog? Why don't we look at making your dog have really positive emotional experiences, because their pain will diminish and it won't be just for the time. It'll probably have a lag effect. So let's look at your lifestyle. What can we do? I'm happy saying that. But when I start talking about, I'm like,
Yeah, the somatosensory complex. Yeah, I'm sure the client just sort of goes, "Whoa, no idea what she's talking about."
No, I'm the same.
Gee, I'm sorry, Dr. Hannah. Is that a foreign language? Are you speaking some language I don't know?
Totally. Totally. Well, one of the other things that I did also want to do, whilst I've got the phone out and then I'm going to put it away, is I wanted to just read you a little bit more, and especially I want to talk about how it can go the other way, in that pain can influence your emotions and your emotions can influence your pain. And I loved this bit. Pain is influenced by emotions, and the cycle of pain and emotions are interrelated. Emotions may directly impact physical changes as well. For example, when you are anxious or angry, your muscles may tighten, and that physical change may contribute to increased pain. Again, it's obvious, isn't it?
Right, exactly. Yeah. Why didn't we think of this ages ago? Because yeah, totally obvious.
Yeah. And again, I'm going to do a nice analogy. I've got a bad back, and when I'm stressed, I really do lift my shoulders up. So when I'm having a bad day, you'll be like, "Oh, what's happened to you, Quasi?" And then if I was also all tense like this and I stepped off the pavement and hurt my back because I've got a bit of a bad back, it will feel doubly worse
Yes.
than if I'm like relaxed, the life's good, the sun's out, everything's calm, I'm not feeling that horrendous stress and tension. Again, it's less likely to hurt as much. And we see that in our pets, slippery floors, slippery floors, slippery floors. We'll talk about anxiety of flooring soon.
Okay, good.
It does make sense, doesn't it?
It does make sense, and there are hundreds, maybe thousands, I don't know, of studies in human medicine showing this exact relationship that you're describing. That the patients with chronic back pain, for instance, maybe they're 90% more likely to have an anxiety type disorder as well. And then vice versa, patients with high anxiety are more likely to develop a chronic pain condition. So who knows which one comes first in all of these patients, chicken or egg, but it doesn't matter. There's an obvious correlation there.
Yeah.
And so why wouldn't there be in our patients? They're mammals, and we've already said they have the same, that we should say they have the same structures in the brain that a human does. I haven't seen any of the functional imaging studies like they've done in people, but I would expect them to be the same. You would see those same spots light up.
Yeah, no,
So
absolutely.
it has to be happening.
And when we look at what's happening in the chronic pain sector as humans, so I was just chatting to a friend about the obsession with pain and the newsletters I get from the Arthritis Foundation, the Creaky Club. I get these newsletters and I'm looking what they're telling their followers. So these humans have signed up to these organizations because they live in pain and they're looking for support. And these people are being given advice about lifestyle, exercise, engagement, social busyness, hobbies. What do you enjoy doing? What really gives you vibes? And we don't do that, any of that
No, right?
yet.
Yes, exactly. We're changing it now with this conversation. We're changing it.
Yeah, exactly. And if anybody's interested in this area, do sign up to these newsletters because they're so cleverly done, because they actually give you this feeling of warmth and being part of a community, that someone's got your back, somebody knows what it feels like, because they've thought of the little things too. It gives you little tips of how to do your cooking without hurting your hands, foods that could be good for you, social engagements, events that are coming on, and you just start feeling like part of a community. And I was just like, we just haven't even tapped into this yet. Unless, do you know of people that are doing stuff like that for animals?
I'm sure that there's probably some, but you I think are the pioneer in this area, and the attendees don't know. But before everybody joined, Hannah and I were talking about some of the things she's doing in our practice, and you're coming up with a sensory garden with different levels of plants so that dogs can walk around and lose themselves in the garden. Like, what a brilliant idea! So people could do that at home too, make a safe space for their dog so that it's not out in the street and it can wander around, or cat friendly in your house with a good cat condo. So I think you're the pioneer here, myself.
Yeah. I know from everybody else. There's the amazing people that I've known from. Lovely Sarah Fisher, she's doing a great work. Sarah Heath. But there's loads of people that are coming out with the ideas. It's just trying to get it into the public domain that it can make a difference, and also allowing our generation to step outside the box that it's got to be a pharmaceutical intervention.
Yes.
And that I'm not with that statement in any shape or form saying goodbye non-steroidals,
No.
long grass. That is not what I'm
Yeah.
saying. But I'm just saying there is definitely, we seem to be following the human sector where we've had a generation where people have been fixated on medications, pill popping, drugs, and now we're coming out the other side with humans of actually we've got our endogenous opioids, we've got our like enkephalins, we've got our serotonins and our dopamines, and we're not using them like we should do. These are in-house little pharmaceutical kits. Please use it. We need to also be teaching owners that the same exists in their dogs.
Absolutely. It's in you're right. In human medicine, that's such a big focus, that distraction focus, that try to keep a positive life focus. And it's all about what we were just talking about, to keep that fear, anxiety, stress down, keep your happy emotions up. And it does, as we've said, there's research that shows that does change the level of pain. Pain is still there, but it's really enhanced if you have fear, anxiety, stress. And I think you're right. There's loads of people doing it, but I couldn't come up with a name right off the top of my head, because we do need more focus on it. We need to get your name out there, everybody's name out there that's doing this, and do train those owners. And we've done it in a way, but through the back door. We've said go take your dog for a walk, but it was always about weight loss. And no owner wants to hear about weight loss, and I get it. I don't want to know that my cat's fat either. He is a little bit, but coming at it from this new direction, it really is probably even more important, that emotional support, that this well-being for your dog, and getting them out there. And yes, it's a pain distraction, but that works. That's not a placebo. That is really shown in human medicine to work. And again, we're working on mammals just like we are mammals. So I expect the same from our mammals, that distraction will work.
And it won't do any harm. It comes with no adverse events, and it's often free of charge. So anybody listening going, what are they talking about? You can do things like, if your dog is less mobile, you can make sure that the garden that your dog can easily locomote around is safe. Obviously, that's my big soapbox. But you can put other things from the external environment that they might not meet on a regular basis because they're not so mobile now. Leaves, different textures, different smells. Bring it in. Bring new plant pots in. Have a friend over. And they're still going to have a really pleasurable time. And those neurochemicals that circulate after having a pleasurable experience, they don't switch off. They linger. So you could just see yourself having these events and going, it's almost like giving an imaginary pain relief pill, but it's going to linger for a duration. And you're not going to do any harm with it. You've seen our expectation pyramid, where it is, first of all, identify the signs, diagnose, manage your expectations, work with your vet. Pain relief is central to everything we do. Weight loss, protecting them in their own home environment, complementary therapies, supplements and diet, and at the top, rebuild. At the top. It's so important that owner that might have always run with their dog, they always used to go and throw the ball on the beach with the dog, they used to go shooting with their dog, they used to do dock diving, and suddenly you say they're not physically able to do that anymore because it's creating these acute flares. You can see he's a day afterwards, 2 days after, he's blinking sore. We can't do this anymore. You've got to give them something else to do, and this is the sort of thing you need to replace it with. So yeah, I'm very passionate about this area. I think it's good.
Yeah, you are a pioneer, and I'm going to use my own old dog as an example. So Labrador, and he used to love to go with us in the car wherever we went. She wanted to go, and she got old and not quite as mobile, so she can't jump up into the car, and I can't pick her up. So, well, I can, but it's not good for either one of us. So got her around, but it took us a while to get her around. We would leave her home, and she would just sit at the garden gate and look so sad. And she really was not interacting at other times either. When we were sitting and watching TV, she used to always come and put her head in a lap, and she would just go lay in a corner. And we thought, oh, okay, just old and cognitive dysfunction, cognitive decline. And then finally I got around to getting her around so that she could go and do the things she enjoyed again. She could now get in the car and go on the rides with us. And Hannah, her whole demeanor changed.
Mm-hmm.
She went back to being the dog that she was. So more interactive, wanting to be with us versus just like, giving up on them. And it was, I consider myself to know a fair amount about pain. And yet here I missed it in my own dog. So how many people are missing it? And so it's not just about the physical health, it's the mental health. My dog is completely different now that she has an activity again.
Yeah. And this is really, because like we do a dog owner's checklist. So when you kind of have a diagnosis, things to stimulate your thought, your lifestyle modifications, new attitudes to your new life. We have a phrase, arthritis is not the end of the road, it's just the start of a new direction. And
Oh,
it's
that's lovely.
people, it's just to make people kind of look at their daily walk, walking around the house, obstacles, activities that are possibly negative for the disease now and activities that are positive. And in there, as you say, you want people to have this little input, have you thought about? But the problem is, ready for this, I'm going to get shot. There's a bit of an academic arrogance, and it's seen as superfluous, and it's seen as fluffy. Well, somebody once told me that my advice was fluffy. How do you
Oh my gosh.
I know, I was like,
Well, if your advice is fluffy, then there's a new definition of fluffy in my book. Fluffy is useful, practical, necessary. I didn't know that's what fluffy meant. So now I know.
Absolutely. But there is that kind of thing, and it happens in the first opinion consults because we're short of time.
Yes.
You feel very much that you're trying to cover the big rocks. You're lifting the big rocks, This is an anti-inflammatory. We must do a blood test and a urine test in 3 months. We must watch out for vomiting, diarrhea. We must get a diagnosis. So come back and please do the x-rays. And the fluffiness, which is really important, it seems to get a little bit neglected. So I'm hoping that lots of vet practices around the country realise that this information is really important. They haven't got the time to do it, so bring them to camp.
That's such a great point, because you're right. And that's why I think a lot of pain is missed. We're not bad vets, but we're just so busy. We don't have time for a pain exam. And if we do a pain exam, we don't have time to talk about the fluffy stuff. It's so we're just scratching the surface. But as a frontline practitioner, we don't have to do it alone. We can utilize resources. And I think that's what we need to share with veterinarians and owners. Go to CAM, go to these resources where you're sending this dog to the right place for help. And you don't have to do it. We don't expect you to do it. And still give the NSAIDs. My dog is on NSAIDs and the ramp, right? It just changed her quality of life. So I think you're absolutely right. How do we get the resources in the hands of the owners and the vets, and the right resources like CAM? Because everybody goes to Google and does a search, but you have to get the right site.
What I find really weird about OA is, let's just compare it to another disease. I confidently say OA is terminal. I know academically it isn't, but unfortunately we have to admit that many of these dogs' quality of life deteriorates to the point that we have to electively euthanize. So there's a real element that it can be a terminal disease for many dogs, as could a condition such as diabetes. Now, when you go into the vets and your dog or cat is diagnosed with diabetes, you'll come away with a handout, an owner's pack, and what to do if a hypoglycemic episode, have some, hypo stop. Let's do a blood check. Cats, we're doing fructosamines, we're doing blood glucose curves, structure, plan. We take it really seriously. We have an owner manual. Nothing in a way. What's that about?
You're absolutely right. And I know, being on the owner side of it too, when you here's your pet, go away, give the NSAIDs, good luck. It's usually not that bad, but here, follow up. And all of us, when you walk, I see the clients doing it. And I know when I've been on that client side, there's chaos in our lobby. You're getting your pet, you're trying to write a check or pay by credit card. Your cat's trying to climb over you. The dog's trying to jump over you. There's a lot of noise. You're going, You just want to get out. And then you get home and don't know what the vet said. And realistically, you shouldn't know. It's chaos. And even if it's not that much chaos, still you get home and you need you really need some reinforcement. So you're right. We should really be, I'm going to use the word pushing, but not in a negative
We should
context.
do a CAM IVAPM, like owner pack that they could download.
Oh, that's a great idea. An IVAPM CAM owner pack. That's a really good idea.
Whoever hasn't watched, so Tamara is president-elect, is that the right phrase? For
Yes.
the IVAPM, which is the International Veterinary Association of Pain Management. Let's do a bit of a plug, actually. They are a global organization that are basically trying to really raise awareness and improve animal welfare through appropriate, attentive pain management, keeping up to date with good clinical practice. And it's so impressive to be part of it. You know, the education that they're putting out to veterinary professionals, but also you are really beginning to start thinking about what we can give to owners more. They do a pain awareness month in September of every year, where they create resources that can go out to vet practices, rehab centers, rehabbers, where there's posters, flyers, information to raise awareness that animals feel pain, and it's our duty of care to minimize any form of suffering. But they also, for any vets or nurses, vet techs that are listening, they also do the CVPP, which is the Certified Veterinary Pain Practitioner course, which is a really globally respected qualification. And you're also in charge of the student push, where all students, new grads, straight out of university, is it new grads and students get free access or something like that,
Right.
isn't it?
That's right. New grads, for the first 2 years after graduation, and as students, we're trying to train these young minds to find that pain and eliminate that pain, prevent the pain if they can.
Yeah, absolutely. So anybody, I'll put all the links after the show about IVAPM. It's so wonderful, and quite often it doesn't get the like attention that it deserves. But yeah, we could do a couple of packs, couldn't we, where people could download all these resources. We do it for other things. I've just signed up for the oh God, what's this thing? Do you have these over there, like Race for Life and things?
Oh yes, yes.
And you get a pack with that. We can do a pack for away.
You're so right. And you know, CAM and IVAPM, it's a perfect match to do this. So now, apologies to the audience, we're totally brainstorming right in front of you.
Right in front of
But
me.
maybe you guys can chime in and help us out, send ideas. We have ideas, but you know, it's fascinating that inadvertently, but now very fortuitously, you also have your big event in September, the Big Walk. Yes. And also focusing. So we have what we call Animal Pain Awareness Month, and you have the Big Walk, and they're both in September. So it's like this amazing crossover of ideas and activities, and really pushing the knowledge. And the reason we chose September was because September is also Pain Awareness Month in human medicine. So trying to tag onto that concept of One Health.
Yes.
And so this is what's happening in humans. So this is obviously what's happening in dogs. And so with that tag on of One Health, and then your event and our event, hopefully we can just keep growing this pain awareness. And the more people that are aware that animals feel pain, then you know they tell 2 people, and then they tell 4, and then we could finally do something about it if we just keep getting this ball rolling.
No, definitely. And it's such an integral part of what we do. And I didn't kind of get into the chronic pain until I was about 10, 11 years into my career. And you kind of reflect back and you go, I don't understand why this wasn't a massive part of my focus and my workload. Because every client that comes to you, if they're in an acute pain setting, they'll go, I'll do anything, I just don't want him to be in pain. It's so important for us to not see our animals in pain, but unfortunately we're still pretty poor at identifying chronic pain over acute pain. Acute pain, we're pretty good now. We're getting better, aren't we? We've got a good there. But with the chronic pain, it's more difficult. I'm going to go back to that, and I really want to read something else which I love, and I'm going to give credit to the incredible Sam Lindley. Do you know Sam Lindley?
I know the name Sam Lindley, but I don't think I've met him.
All right, so Sam Lindley she runs the Western Veterinary Acupuncture Group up in Longview in Scotland.
Okay.
And she is a veterinarian that's been working in the chronic pain sector for years. And her content's just fantastic. And she's just written a chapter in a book called Animal Psychology with Sagi, who's the lead clinical behaviourist at Bristol. And her chapter on pain and behaviour is fantastic. And what I found really good, so there's a couple of quotes. Pain is an arresting sensation. Pain is frightening. Why is it frightening? Because it's adaptive pain signals existing or potential damage. That pain is signaling to the animal that it must stop, it must flee, and it must protect itself. And I got it right. So fear and acute pain. Yeah.
Mhm.
You put your hand in your fire. I'm not going to do that again. I just need to get away. But I never really thought about this before. When she was talking about chronic pain being maladaptive, where is it? Is much more linked with anxiety. So anxiety is the chronic anticipation of a threatening or negative stimulus. So that makes sense. I'm anxious that tomorrow will be a bad day at work. I'm anxious that I haven't got my tax return in. I'm anxious because you're like, oh God, negative experience is just around the corner. So anxiety, but anxiety is of no benefit and it depletes the body. So we've got adaptive pain, acute pain, so your hand in your fire, stab, surgical wounds. That's causing trauma. Oh my God, I must get away from it and I must heal and I never want it to happen again. That's really logical. So fear, yeah, you can kind of go, yeah, you're allowed to be fearful. But in chronic pain that's linked to anxiety, chronic pain weighs you down, anxiety weighs you down. They both lead to a chronic stress situation, which burns your body and your brain out, isn't it? But I've never really thought about the fear, anxiety mirroring the adaptive and maladaptive. I don't know. Have you seen it like that before?
Yeah, I think it's such a good way to put it because like you said, the acute pain is for survival. So it's an evolutionary instinct, and it's never going to go away. So we have to learn how to work with this in our pets and our patients. But back when dinosaurs roamed the world, and if you were a saber-toothed tiger and the dinosaur's looking for lunch, you've got two choices. You can run really fast, or if you can't run, you can hide, right? And you hide until maybe the pain goes away till you heal. But if it's chronic pain and it doesn't heal, now that's really not a survival mechanism anymore because it's that now I hide, now I run, right? And maybe again, short duration, but this long ongoing chronic pain, like you said, it doesn't, now it's not survival and it just creates that fear, anxiety, and stress. If the acute pain did, which was good, it's what made us run. But now this fear, anxiety, and stress has no value whatsoever. And like you said, now both the pain and the fear, anxiety, and stress cause this. They're both negative, and two negatives makes one really big negative.
Yeah.
And there's just no purpose for this pain. We need to alleviate the pain and go back to where we started. Support then the emotional health of the patient too. It's not just the pain; it's the emotion that comes with it.
Yeah, absolutely. And I just thought it was good that she made it so clear.
She did, yeah.
And this is another sentence she said, which I thought was brilliant. The chronic nature of maladaptive pain signals to the animal that they are continuously under threat, that it must pay attention to the pain, that it's vigilant and it must be hypervigilant and more defensive and avoid things that could possibly even make the pain worse. And that makes so much sense.
Yeah.
And when people tell me that people do still say to me, "Are you still obsessed about arthritis?" I'm like, "Yep." They're like, "Really? Aren't you bored yet?" I'm like, "How can you be?" Because they just see pain as this 2D experience. But now I'm hoping people are like, "Oh yeah, acute pain, that's got, it's got purpose. Chronic pain, no, my dog's got chronic OA. There's no purpose to it. Oh, it's going to be affecting their emotional system. Oh, I can do things. I've got a big toolbox now. I can distract them. I can exercise them. I can make their life easier. I can get the weight off. I can make their bed better. I can use the pharmaceuticals. I can use my." Then you start going, well, actually, I feel like I'm really inputting positivity into my dog's life. Then I'm going to throw this one at you. What about caregiver by proxy, where when the owner is in a better emotional state, they convey that positivity? Does the dog follow suit? I personally am going to put my hands up and say yes.
Yes, yes.
I really felt that, like, if I was struggling with Holly, if I was low, if I was down, if I was not dealing with the fact that I was watching her deteriorate, it almost felt like she was on that slope with me. But when life was good and we kind of reverberated, and she saw me happy, she was happy, and then she had the fix of all those lovely neurochemicals, and she got happier and I got happier. It was kind of nice. Have you experienced the same?
Yes, and it is a great example again of our focus today, and it's that emotional impact and how distraction can help, and it, the placebo effect. Okay, so we think a dog is getting a drug it's an NSAID and it's really a placebo, but we think it's working, and that makes us happy. So we go take our let's go, let's go, let's go. So the placebo effect is not wasted because of what you're just saying. We say, okay, if they really need the drug, they need the drug, but we can have both. And so if I'm like, oh, I want to go for a walk. Look how much better my dog's doing. Oh, look at you. And we talk, oh, you're so cute. Talk like that. And they go, oh. So that positive emotion, then I totally agree. Because every time we do something like that with our dog, oh, we know we can get that response out of them. There's like only 4 dogs on the planet that wouldn't respond to that.
No. It's almost like their brain floods with chemicals quicker than us. You ever think that? Like, for somebody to talk to me and to improve my mood, it will take a little, they'll talk me through it, and I'll eventually start having all those endorphins kick off. But if I say to them, let's go, she would, and it's almost like there's a little bit more of a primitive nature to their brains. They're quick up, quick down in many ways. Do you feel the same?
Yeah, absolutely. I agree. And, that primitive brain, there's an interesting quote. It's a geeky pathophysiologic pain paper that I like, an old one. And there's a couple of things in that paper that it's all good. But one of the things that really stands out is that probably primitive brain. We're not behaviorists, so that's probably the wrong term. But I think everyone listening understands what we mean. That's actually probably worse for them. Because so in this instance where they're up, yay, but when we're painful, we can reason. We know what pain is. They don't have any idea what this horrible sensation is that could make them die. They don't know what this is. Plus, we can reason through it. If I take my NSAIDs, it will get better. If I go for a walk, it will get better. Whatever
Tomorrow morning, when I wake up, it might be better.
Yeah. And they don't have that capacity. So all they know is right now they're really, really painful. And like you said, what could make that worse? I'm going to hide from it. So I'm going to hide under the bed because even though my owner loves to pat me on the head, that hurts right now. And so, that on-off thing is, I think it's fascinating. And I agree. It doesn't work for us. Maybe you said a while ago, if you walked in with the Red Bull and won the lottery, that might do it. Like that, I could be immediately on for that one.
But there's a little bit more conditions there. But you're right in that there are the benefits of, I can't remember, I wrote it down. It's part of the brain that we have that they don't have. I didn't write it down because it was too long. But we know that animals, such as the dog, live very much in the now. So they don't have the foresight and the high insight. So they live in the experience of the now. And that obviously is horrendous, thinking that an animal in pain doesn't see a way out. They don't see an end to it. They don't see the end of suffering. Yes, we as humans do have the ability to be positive outlookers and go, oh, tomorrow morning I might feel better. But we also can reverse that and be our own worst enemies and go, it's here forever. Ian Self that I first heard that from. And we were at the PSABA and I was listening to him lecture. And that was like a knife. I was like, it is our duty of care to do something about this. Leaving an animal in pain and feeling hopeless is pretty diabolical. But yes, so now I'm going to be really, really proactive. In our list, we were going to do a little bit of a covering about the influence of emotion non-pharmaceutically, influencing emotion non-pharmaceutically, influencing emotion pharmaceutically. So therefore, we've talked about lifestyle changes. We've talked about getting them up, getting them out, doing things, new environments, new smells, new experiences, and how that can cause a release of positive neurotransmitters, which we know can influence emotional state as well as pain state. We do dabble with medications that have an influence on emotion, and I think they're really underutilized. I think partly because the profession don't really know enough about it yet. I think we're first opinion practitioners like me are a little bit like playing with their mind. Yeah, I know it sounds daft. You go from, but you give drugs all the time. I'm playing with his mind though. There are a few medications out there that are reasonably well understood that can be brought into a chronic pain plan. Are you happy to talk about them?
Would love, yes. Hopefully you are too, because you have to tell me your experience as well. The thing, I completely agree with you, and we didn't know. This is like relatively new when we're thinking about pain, to think about what's going on in the brain. The brain's not just perceiving it, right? It's not just registering it, but there's actually there's changes in the brain as well. Mm-hmm. And so I'm going to say the old days, I don't know how old, but the old days when people with pain that was totally unresolved and finally, and no lesion, or maybe it's osteoarthritis, but the pain is way worse than osteoarthritis should be, right? So maybe the lesion didn't match the level, or there's no lesion. Doctors would say it's in your head. It's all in your head. Well, the interesting thing is it is, but not in the way they meant it. It's part of the pain pathway. And when we're looking at some of those non-traditional pharmaceuticals like the anxiolytics, there's a part of the pain pathway that we don't often talk about. We talk about the first four, the transduction, transmission, modulation, and perception, and those are the ones that are most integral to acute pain. But there's this descending inhibitory limb too that comes from the brain back down to the spinal cord that's also part of modulation. But we don't usually manipulate that limb necessarily, not going after it like with chronic pain. But with chronic pain, there's often a dysfunction of this inhibitory limb. So we're not getting that feedback to the spinal cord from the brain going, hey, like, I can't take all of this pain. So using things like some of the norepinephrine and serotonin reuptake inhibitors, amitriptyline, and other things like acupuncture works in part by that descending inhibitory limb, cannabinoids work in part. So trying to restore that part of the pain pathway or boost it, maybe it's not bad, it just needs some help. That actually can be the answer for some patients. You've tried everything else and nothing's working. This is where we need to work in that descending limb. And it's absolutely fascinating. Sorry, it's like you put a quarter into one of those little horses at the drugstore. Like,
keep going. Because I think there is, I haven't used them extensively at all. I'm still like on my learning journey. And I want to. I'm desperate to start getting them into my pain kind of like protocols for people. So I should imagine, you've got and let's use Labrador again. They're quite sad. And they come in and head to blow and they look up to you. Nothing really sparks them anymore. Nothing really floats their boat. Mm-hmm. And you've got them maybe on a non-steroidal or monoclonal antibody. You've got them, maybe you've played around a bit with the mantidines and the gabapentinoids. You've kind of been getting the weight off. You've got them in omega-3 in the background. Is it then that you would start thinking, I think we need to lift your mood as well as influence your pain? It's a difficult one, because I think for me as a first opinion practitioner, I'd be thinking, am I missing something? Is there some pain focus that I've missed? Is there sepsis? Is there a comorbidity? Right. Am I missing something before I start playing with their emotional state? How do you juggle it all?
Do you know, it is difficult, isn't it? And in fairness to what you said, I need to make sure I'm not missing something. That really is the more immediate threat to life. So is there sepsis? We need to know first. So I think that's a perfectly logical procession. And then I think probably fairly quickly, though, you rule out the most obvious and the most life-threatening issues. And then we can start thinking about, okay, is it, I'm going to say just pain, that's terrible. But yes. I mean only pain and not another comorbidity when I said just pain. So now should we, what progression should we have with treatment? And it's certainly logical to start with the NSAIDs, the monoclonal antibodies, the things we know have high potency, likely to work, lower caregiver burden, because NSAIDs are once a day, monoclonal antibodies are once a month. So we want to keep the owner able to do all of this as well. So I think it's completely logical. And I start there too. And I think then we start adding in gabapentin or some other treatment, adding in acupuncture. And I personally think we probably wait too long to start thinking about
Yes.
should we be manipulating the descending inhibitory limb, because it's not going, it shouldn't be first line,
No.
but it shouldn't be last line either. And I think it is last line now. And it's not on purpose. It's because this is really new. It's fairly new in human medicine too, but we see emerging drugs like duloxetine that is a specific serotonin norepinephrine reuptake inhibitor used for pain.
Yes.
So it's getting more mainstream in human medicine, and we need to bring that in. So it's not offensive to me that we haven't focused on it. We didn't know.
Yeah, no.
We know.
Do you because would you say that you use amitriptyline quite a lot? Because that's actually really used very commonly in human medicine.
Yeah.
And amitriptyline, I think it's in the same family as a drug that was developed for depression, and they realized that these people that were treating for depression actually were getting pain control. They're getting improved pain, weren't they? And they were like, whoa.
Yeah, right.
Yeah. And I think it's prescribed for like neuropathic pain in humans, but it's quite widely used where it's not very widely used in veterinary care.
No, it's not. And to answer to your question, embarrassingly, no, I don't use it enough. I'm not using loads of it, and probably I definitely know I need to be using more, and and probably loads. And the patient, and hopefully everybody's listening that's listening to knows we don't mean we mean that 10% of the population that really needs the drug. So we're not every puppy needs amitriptyline.
No, please don't start giving it around.
Yeah, it's not necessarily. We need better drugs in that category too, because it's not necessarily the easiest one. I don't know what the economics are for you guys, but it's not the cheapest. And it's often these big dogs that need the extra help. And apparently, I've never tasted it, but if you see a dog take it, or especially a cat, it apparently tastes bad. So it's not that user friendly. So it's an option that should be on everybody's list, but we should also be looking for what's out there that could be even better in this same category of working in the descending inhibitory limb.
Yeah. Do you use so for the people that are a bit more technical, amitriptyline works very much on serotonin reuptake inhibition, norepinephrine reuptake inhibition, but we have another drug that is licensed called tramadol. So we have it over here, and it is now a licensed product. And I do feel sorry for the company because it came to license when a paper in Greyhounds came out saying it doesn't really offer much pain relief. And you can imagine the company going, what?
Yeah.
Excuse me? But I know that there's still a lot of people that do integrate it into their pain management plan, not because of its synthetic opioid effect and expecting it to work on the opioid receptors and create amazing pain relief, but they use it very much for the same, the serotonin reuptake, the norepinephrine reuptake, etc. Do you use it much?
I don't use it a lot, only because of the logistics. Here, unfortunately, it's one of the drugs that gets diverted into human abuse. So we're really cautious with the clients that we send it home with. And darn it, because you're right, in cats, they get that opioid effect. So it's a better drug, a more potent drug in cats than dogs. Dogs, some get the opioid effect. It depends on their metabolism. But all of them, I would assume, get the serotonin and norepinephrine reuptake inhibition. And you're absolutely right. That is a valid mechanism of action and exactly what we're talking about that we need. Yeah. So I think if you have the licensed product, yes, it should be a part of an analgesic protocol. I would never expect it to work alone. Every patient's an individual, but it's really working at a very discrete part of the pain pathway. So I would expect it to need some support. But maybe any individual animal would work by itself. But yeah, that's fantastic that you have it licensed.
Oh yeah, we have it licensed. Is there what other ones? I think those are the two that I kind of wrote down. But I've actually just had a little bit of a brainwave. I'm going to totally abuse you being here for a few minutes. Constant rate infusions. How often at your clinic? So in the UK and historically, you come in with an arthritic dog who's going through an acute flare, and the owner, I think, expects the vet to be able to give them something within 15 minutes they can walk out, and the vet feels the owner wants them to give them something within 15 minutes and walk out. And I've been recently doing more constant rate infusions and loving it. And do you do that?
Absolutely. And Not as much as I would like to, because there's certainly an economic and time conversation with the owner. It's not very expensive and doesn't take much of our time, but it still is economic and time. And because we don't, you and I are probably doing the same thing. We're learning as we go with these infusions. And ketamine is the one I think we probably run the most. And it's because it works in a very different part of the pain pathway than the NSAIDs and these other, the opioids. It works at that spinal cord to break the pain cycle, to decrease the overall intensity of the pain. We still need the distraction techniques like we've already talked about, and maybe the NSAIDs or acupuncture. But it really can make a huge difference in that patient's pain level, because it's counteracting what we call wind up or central sensitization or central plasticity, but it's that amplification. So ketamine brings it back down to a more treatable level. And it doesn't work in every patient, but when it does work, it can make a huge difference. So yeah, I try to do it as often as I can. And I'm going to use the word push again. I push owners, please let us do this, because your dog really needs it, and I think I can make a difference.
Yeah.
So I don't get to do it as often as I want.
No, and I think it'd be lovely if owners go in to their vets with that open mind, so that vets like me and yourself can feel that we can have that conversation. How about you just leave Freddie here for, probably the next 4 or 5 hours? Just stay with us. Because then we do have more options. Do you guys use subcut ketamine over there? Because Matt Gurney's been doing a lot of work.
Yeah, since I saw that blog on his website, the Zero Pain Philosophy website, I started doing that as well, the subcutaneous or subcut. Now I feel British, subcut ketamine. And we have some unpublished and not just some like private clinic research.
Yeah.
The CRI works faster and better because we really get that pain level low, right? Because we're giving it IV. The subcutaneous is a little bit slower and not as much pain relief, but it's a big bonus for us to be able to do that. The dog doesn't have to stay in the clinic. It's very inexpensive. The owner can just come by, get its dog's injection, and off it goes again. We have it as, once we've made the diagnosis that that's what we're going to do, it's actually in our practice a technician appointment even. So that saves time waiting for the vet, and it saves money. And so, not that everybody should do that. I'm just saying like how we make it really easy for the owner to do.
Yeah.
And I started the way it said on the website once a month. And I don't know what happened with you, but for me, that once a month is more of a maintenance interval once I get there. So I'm doing it at least once weekly. And if they're really painful, I've had several that we've done daily or every other day. Mm-hmm. Yeah, you too?
No, I haven't. I've done it subcut monthly, but I don't think I've had the confidence to kind of ramp it up. But now hearing that you are, I will do exactly the same.
Yeah.
100%. The lovely Luke, who's one of our ambassadors, he's so cool. He's so cool. Look at his photo, so cool. So constant rate infusions, Luke, are actually quite easy to do, and all first opinion practices will be able to do them. It's again, a conversation needs to be had. I think practices don't think owners want that kind of intervention. They fear of the cost. They want to keep their dog with them. They don't want the inconvenience of coming back. They were just expecting a 15-minute consult. You want to keep my dog for 4 hours, and you want it to be 50, 100 pounds more. So vets have fear of that. And I think owners don't know to suggest that, I'm happy for us to try all avenues. So I can imagine it's something that will grow. And I think it's appropriate because I was thinking the other day, when we have these dogs that come in acute flare and their mood is ridiculously low and they're really struggling, and we give them some pills and send them away again, I'm like, do you know what? If I went to the hospital and I walked in going, oh God, I don't know if I want to go on, I'd expect them to admit me.
Right. Do more.
Yeah, and it is kind of, it's always, but osteoarthritis for me is full of those idiosyncrasies. It's a near terminal disease. It's ridiculously common. It's the leading cause of suffering, and it still doesn't have an owner introduction pack.
I like the way you brought that back up. Good for you. We do need an owner introduction.
We need to do that.
There's so much of osteoarthritis that I think we didn't understand. And so if we didn't and we were trained in medicine, then the owners certainly probably don't understand. And that is, it's not just the joint being painful. Oh, yeah, that's what starts the pain syndrome. But anybody that's had ongoing chronic pain, and I hope it's none of our listeners, but anybody, if you've had ongoing chronic pain that's not been adequately treated, it impacts your entire body. You can feel like, because of that central sensitization. So if I pinch myself right like this right now, it doesn't hurt. But if I was a person who had long-standing osteoarthritis and I pinched myself, that could potentially hurt. And so you get this body-wide pain response. And then as we've been talking, you also get the emotional impact of that pain. So it's not just, the joint's painful. Osteoarthritis is so much more than that. It is a whole body disease. And I love that you call it a terminal disease, because you're right. I would say most of the patients that we euthanize in our practice, unless it's a horrific injury or surgical lesion that we can't fix, it's for osteoarthritis.
Well, this was interesting. You have to listen to the live I did with Daniel O'Neill last Thursday.
Yeah.
And he played with the phrase dying of pain or dying with pain. And he was like, well, OA fits into dying with pain because they're not necessarily going to die of it, but they're going to suffer with it until they do go. And I was like, oh, play with words, but really powerful.
Yeah, absolutely.
Can I be cheeky and ask you, because you mentioned CBD with the whole descending inhibitory, and I know that people are going to prick their ears up. We're still, in this country, it isn't something that's recognised veterinary practice, so it's not the first port of call by any means.
Right.
We are encouraged to follow the prescribing cascade. And if we have a condition such as osteoarthritis, which is a nociceptive inflammatory disease with potential neurogenic pain, there is a plan. And we'll start with the non-steroidals and the monoclonal antibodies, and we'll bring in our adjuncts to start working on maybe the neurogenic, neuropathic component. And if we find that that is not controlling the pain, then as we go down the prescribing cascade, we can start to go towards CBD. But it's quite near the end. And one of the reasons is that it's been recognized as a medicinal product, but there are no products in the market that we can resort to. In that there's a couple of CBD products in the human sector, but they're just not affordable at all. So we are looking at using human food supplements that have got a certificate of analysis. They're really high grade, but we can use it later. Now, are you the same? And it's different state to state over there, isn't it?
Yes, it is. That always complicates it. I'm the same, and I think it might be interesting to have a CBD expert really talking about the stuff that I don't know. I don't know a lot, but I'm with you. Right, for me right now, it's a lower tier for a choice, and part of it is because it's not as potent as some of these other things we've talked about, and we're right on the cusp of getting the anti-nerve growth factor monoclonal antibodies. We don't have them. So that's why ketamine right now is sort of my go-to. Once the NSAIDs have proven not to be effective, like ketamine is my next choice. So once we have those, then I'm going to be very excited. But I think we dabble more. And of course, we don't have any NSAIDs approved in the US for chronic pain in cats, the other species. But we dabble, I think, maybe more than we would if we had some of the more powerful drugs. But the CBD, I do think it plays a role. There are cannabinoid receptors in the pain pathway. But I think we're on a journey of, you said it, finding the medicinal products, because just blowing marijuana smoke in your dog's face is not the point. It really needs to be.
Wow.
Oh, you haven't had clients ask you that? Maybe we're in Washington State. It's recreationally approved, and so they're not ashamed to tell us. So yeah, would it work, Doc, if I blow smoke in his face? Yeah,
wow.
So many levels, no. So we're looking for the medicinal products so that we have the confidence that it's really doing what it says. Otherwise, it's herbal medicine, and nothing wrong with herbal medicine, but it's a very lower tier even, because we don't have the research and the confidence. Not that it's bad, but we don't have the knowledge.
Yeah.
So for me now, it is still a fairly low option, but it is it's on my list as an option.
Yeah. I had a very facetious slide in one of my courses, a couple of them, and it's a dog and he's got a speech bubble and he's kind of like looking a bit bemused, and it's like, so you want me to wait 6 weeks for the pain relief to kick in? And I was like, it's just prompting thought, isn't it? I think a lot of people are so in fear of using medications that they resort to what seems softer, seems a lot kinder, but they forget the real obvious in the middle of it's going to take a lot of time to get any benefit if it does.
Right.
And, you can be both. I've always said to people, you can be both naturopathic and herbal and supplement and Western-based allopathic type. You don't have to pick a side. You can use evidence-based interventions that we know how quickly they work, how long they're going to work, dosing frequency, and you can in the background be bringing these other stuff in. And if they work, then the logic says we'll be able to drop our medicine. You can be happy in both sectors, yeah?
I totally agree. And that, it's always called complementary and alternative medicine. And to me, like, chuck the word alternative. It's complementary. I love my acupuncture, but I would never throw away my NSAIDs. We should be working with both. We should be working with what that body needs.
Yeah.
So, yeah, totally, absolutely believe in both.
So, do you fancy doing our 10 top tips where you do 5, I do 5, taking 10? And it's focused very much on stuff that is applicable to everybody that they can do. So you've done it before, so you'll be fine. I'm sure you have. So number 10 from me, my big tip for people is flooring. We have the hashtag more rugs, less drugs. And we were talking earlier about why people don't take the fluffy stuff seriously. I did a talk for IVAPM recently, didn't I? Where I wanted to bring in the science of proprioception, so people could understand the scientific reasons that these dogs lose balance, traction, etc., and they become more vulnerable on these surfaces, to win their academic minds into it being a positive intervention. So I was doing the cheeky, there is science here. But yes, more rugs, less drugs. Number 9 for you.
Number 9. Wow, it's a tough one because in a way it should be number 1, but they all should be number 1, shouldn't they? And I love the rugs, the mobility. So getting your dog out for a walk, if you're a dog and cat owner, playing a little game with your cat. You don't need to go crazy with the laser pointer if they have osteoarthritis. But one of our old dogs got to where didn't really want to walk much anymore, and he didn't want to play ball. But if we would just roll the ball on the floor, he'd go along and pick it up, and he was so happy. So it's some kind of just get them moving as much as you can. Every little bit counts, and you don't want them to run a marathon, so don't expect them to do it. You don't want to do it if you're 80. Don't make your dog do it if he feels 80. So just that mobility enrichment.
Yeah. There's Carrie Smith, who's a lovely PT from Canada. She says, motion is lotion.
I like that. That's awesome.
Good, isn't it? Yeah. Number 8 for me is the classic. We've got so much to talk about tonight. I don't mind bringing it forward, but weight control. And I was chatting to somebody from IVC, one of our corporates here, so one of the people and I was telling them how much I love doing my weight control consults now, and I think they were quite bemused. I've been qualified 20 years, first opinion practitioner, supposed to be highly experienced, really into all different kinds of surgery and stuff. And I'm like, love my weight clinics. And he said, why? And I said, because the impact on their health, their emotional state, their physical capabilities is just incredible. And I think we forget that, don't we? Weight loss.
Yeah, absolutely.
Number 7.
Number 7 is, of course, these are all intertwined as we started this talk, is giving your pet that emotional boost. So I'm sure emotion's going to come in higher too on some of ours, but like we were talking about, the walk is one of them. But even just talk, oh, come on, let's play. You're so cute, or however it is that you talk to your dog.
Yeah.
Being positive, because that gives them that positive. We can see that they are more positive. And as we've said, that positivity changes the intensity of pain. So do smoochies with your dog or whatever it is you do to make it happy. It helps. It's good. And
Yeah.
it's good for us too. It makes me happy.
Yeah, no, I love that one. I'm going to play with that one as well. Why do we feed dogs in bowls? Have you ever thought it's really about us? I can't see the benefits. So why? It's for us to keep our floors clean. The bowls are easy to clean. We keep it contained. They can eat it reasonably quickly. It's done, finished, push it away. Followers, correct me if I'm wrong. If I've missed a real key point of why dogs get fed in bowls, because I have that understanding, don't feed them in a bowl. Scatter feed. Hide it around the house. Make that pleasant, happy eating time as long as possible and as varied. So they have to go and look for their food. They might hide it in things. I used to put my dog's food in a cardboard box and put like screwed up paper on top, so she'd have to root around. Because when I was a kid, I used to love games like that. Do you remember? Lucky Dip. Do you remember Lucky Dip, where you put your hand in a bowl and you'd find a wrapped up present, and that's what you got at the party? Did you ever do Lucky Dip?
No, that game didn't come across the ocean with the pilgrim. Dang,
Lucky
I wish it
Dip.
did. That sounds
There
like
you go.
fun. I'm gonna have to do it.
Lucky Dip for your dog. There you go. Number 5.
Is it my turn again?
Yes, it's your turn. Yeah.
That was number 6. 5 is the other thing that we mentioned about enrichment and mobility is give your dog a way to enjoy what it used to enjoy. So those ramps that get into the car, if it likes to go on car rides, a ramp to get out of your house to get it into the yard, a ramp or some little steps to get it into your bed if it sleeps with you. But this is back again to that emotional state. It's not just about mobility and the dog getting where it wants to be. It's emotionally also where it wants to be, and you'll notice the difference.
Yeah, that's really good one, and I love the fact that you're into this as much as I am. Dr. Tamara Grubb believes the same. It's great. Right, my next one is try and be more semi-objective in your assessments. So this is something that's really lacking in OA management, but it's very prevalent in other chronic diseases. We do blood checks, we do urine checks, we check glucose levels, we even grade gingivitis and disease, but we don't grade, we don't try and score a dog's pain state so that we've got something to refer back to once we've started a new intervention. And your emotional state can really confuse you as to whether your dog's doing well or not. And I've had so many owners who'll come in and they'll be like, oh, he's no better at all. I'm questioning them. It turns out he's done actually a lot better. And they're like, oh, right. Now, this is what these questionnaires do for you. They prompt you to think and become more objective. So when you go back to your vet and they've just put you on a new medication at your 4-week check, you can say, I know he's better because of this, this, and this. Or I know he's better because his score has lowered. And then we can go, great, let's stay on this medication. This is working. Whereas what actually happens most of the time, if people come in and go, I don't really know, I think so, but I'm not really sure. So use the tools that are available, these questionnaires. Have you worked on any of them? Or
no, I haven't done that. I use a number of them, but I didn't do the research on any of them. I wish I had, because they're amazing. And you're right. Without having some kind of endpoint to see, it's just like giving candy out. Like, oh, I don't know what's happening. You have to have that endpoint. And as pet owners, the pet owners that are watching, you want that endpoint. Maybe you didn't know it yet, but you want to know how to follow the progress of your dog, because if something's not working, you want to be able to go and get something else because there's more options. Come to the vet and say, this one's not helping. And then, like you said, we would review the checklist too and see if there really is no difference. But they're brilliant.
They are really brilliant, and they're free of charge. So, Caroline, I'm not ignoring your comment up here when you were asking about the dose of ketamine. I honestly don't know if legally I'm even allowed to say it because this is going out to the public. So I think for the VMD, if I start talking about dose rates, they're going to probably be a bit concerned. But you can always email me. That's fine. And with regards to the questionnaires, So there is the University of Pennsylvania has the CBPI that you can upload and download. So that is University of Penn CBPI. You'll find it. Helsinki. I definitely know you can get that from fourleg.com. And load, you can download from Elanco. So they're the three common ones that we use here in the UK. What number are we up to? 4. But let's do this question very quickly. I read there may be a blood test that can measure pain and if pet veins are working. I've not heard of that. Have you?
I have not. We desperately want that, but I haven't heard that there is one yet. But I hope I'm wrong. Hannah will have to look this up immediately when we get off.
Yeah.
It's been a very elusive test because there's so many components and facets to pain and causes of pain. So it's been impossible up to now, but hopefully I would love that.
Yeah. Joe, if you've got access to any papers or articles, then please do send them my way, because I certainly haven't heard of anything. And your project is the most exciting currently, is Pain Trace. You know, this really excited to see where that goes.
Yeah, me too. It's a fascinating instrument, and I don't know how it works. It's completely proprietary, but it is amazing. So people that don't know what Pain Trace is, it's actually just a little unit that measures biophysiologic changes, signals, and can quantify the pain to a certain extent. So it makes little tracings, and if it makes downward tracings, because pain is bad. So I like if the traces downward. And if it's in the blue level, it's no or low pain, and then yellow is mild, and orange is moderate, and red is really bad. And it calibrates itself to each patient. So it's absolutely fascinating, and it works in anesthetized patients, and it works in awake patients, and really, really fascinating. So yeah, I can't wait to learn more about it, because
Are you using it in your clinic now?
We are using it some. We would use it more if I was there more, but just like everything else, it needs a champion in the clinic. You know, like for geriatric dogs, I think they should all get an ECG. But if I'm not there to do the ECG, we don't have, you know, like it's that kind of thing.
Yes.
So,
yeah. No, absolutely. Well, hopefully they're going to send, when they get to the UK, they're going to send me one to start using, because I'm really fascinated.
Yeah. And you're in a better situation, I think, to use it and really evaluate it. Because I'm still doing a lot of anesthesia, and so don't really have the time. And so I really think I can't wait to hear what you think.
No, definitely. Yeah. So number 4 for me is be really open to modifying their exercise, and don't just think modifying exercise is reducing it, because there's a terrible habit for people to go, oh, just exercise them little and often, and people go little, okay, and they really reduce the exercise down. Exercise can be so varied. You can have different terrains, different slopes, different environments. You can have short walks. You can have transition sits to stands, different gaits. You can do different obstacles. You can do like targeted exercise. So exercise is so important. And again, it's so common. It's so obvious. I've got a bad back, but if I get out and I go for a dog walk, a run, a swim, whatever, I come back feeling so much better. Yeah. And we, again, don't use that in our care for our dogs. I think we forget how powerful it can be. So think about exercise, maybe have a check-in with a physiotherapist, see if you can get advice from your vets, from your nurses, but open your mind to that section. Number 3.
Yep, I love yours. And I wanted to add really quickly, Zoetis has some good scales and animations of pain too on their website. If you Google Zoetis osteoarthritis, their website will come up, and they have some good things there too for owners and veterinarians. My number 3 is treat when the dog needs treatment. It drives me crazy to have our colleagues say, well, I'm not going to put this dog on non-steroidals or a monoclonal antibody or even acupuncture because it's young. You know, we don't want to start treating when it's young. We'd have to treat it for the rest of its life. Yeah, osteoarthritis is a lifelong disease. So yes, but treat when there's pain. Don't be afraid to start when the dog needs the treatment.
Yeah, I totally agree. But that goes down to people being in fear that they're going to run out of options. It's the bizarrest thing. People go, oh, we'll wait till we really need it. And why? well, what happens if we don't have other options thereafter? There are plenty of options.
Yes.
You're not going to run out easily.
And they're in pain right now. And you're more likely to run out of options if you don't start now, because maybe in that young dog, you could just start with a joint health diet, so it doesn't have to be drugs, but that would prolong the time for the pain to ramp up. Like it'd be a lot longer pain reduced life. So we don't have the central sensitization and the really difficult pain syndromes to treat. So you're way better off to start when the pain starts.
Yeah, totally agree. But I think it is just those myths that circulate. There's always myths circulating, aren't there? And that's going to be my number 2, actually, is try not to get caught up in housewives' tales and myths, and do take the time to just go and read. The CAM website is brand spanking new. We've only had it for about 2 months now. Cost us £15,000.
Ooh,
That's right.
You need to get the Red Bull and go win the lottery.
I know. I just need a really, really dog dedicated fairy godfather.
Yes, that would be awesome.
Yeah, so the website is up, and the web developers were always saying to me, can you stop giving away free content? Stop it. Just stop it. We need people to join the member zone. That's how we're going to keep going. We need people to step over the paywall. And I was like, oh, but we must tell them this and we must tell them that. So the free of charge content is incredible. There is so much there. It's really easy to navigate. It's super fast now, so you can pop around the show. But we have also got the member zone, and behind the member zone, which is only 25 quid for the year, you did one payment. You get all the CAM downloadable booklets. That's worth £10. There's 15 downloadable booklets. You get the CAM Essentials course, which is £20. So it's already 30 quid's worth of stuff. You have tea and chats with me once a month in a private Facebook group. So you get to go, and with me and Dr. Katie Smith, we chat to you, with you once a month. You get 10% off the CAM shop. You get 25% off of our Why Don't You Listen children's book. And there's more. There's going to be discount vouchers. There's CAM conversations. There's talks with the experts. It's amazing. So please go over to the member zone and join, because the money, I promise you, is going straight back into CAM to keep us going. And up until the end of July, you'll also get entered free into the big walk. And that's another £10 worth. So it's really, really worth it. It's 25 quid and money goes back into CAM. So read about, don't get stuck in myths. Go to where the education is. Number 1.
Do you know, it's so funny because I'm not going to change it now because of what you just said. Mine was education. And so one and 2 are both education. And as I'm listening to you, I'm like, that's mine. That's mine. I should change it. Like, no, I shouldn't change it. It should be my number 1 as well. Without the education of what's going on, and the osteoarthritis is not just the joint, that it's the whole dog, and that dogs do have emotions and an emotional drain when they're painful. Getting that education out there, that's the best way for us to help the dog. And for everybody listening, veterinarians, veterinary nurses, pet owners, that's what we want to do, right? That's why we're here. And your website is the best for education. It really, really is the best. There's so much on your website. And I love that you have focused a lot on pet owners, because if the owner doesn't see pain and bring the dog to us, we can't treat it. So as good as our heart might be, as nice as our clinic might be with the sensory garden, if the owners aren't seeing it and bringing them in, we're not helping. So I love that you focus on pet.
Well, I have to give a little bit of credit to John Ennis for this, believe it or not. I was already very focused on the owner. I always have been. But I listened to a talk that he did, that when they created LOAD, the Liverpool Osteoarthritis in Dog Study, they recruited people to create the tool through a radio invitation. So they put it out on the radio for the local radio station. But we're recruiting osteoarthritic dogs for a study we're doing. And 30% of the people that stepped forward were owners with dogs on medications. They knew that their dog had arthritis, they knew it was painful. They were seeing the vet and the dog was on medication. 30% were attending the vet, but their dogs weren't on medication. So there was confusion, not education to get them into the right place. but 30% of the people that stepped forward knew their dog had arthritis, knew it was painful, and weren't going to the vet. And that's always really bugged me, thinking, well, what is the obstacle? And I think it's a combination. I think there's fear. I think there's finances. I think there's fear of not being able to commit to a treatment plan that the vet suggests, fear of it being an invasive intervention. So many reasons that they're really hesitant. One big one I know that people talk about is fear of being judged, fear of bringing them in too late and being told off. And so what CAM really tries to do is make sure that anybody from any background can tap into information and give them the courage and the confidence to go and seek the vet care that they need. So yeah, well done, John Innes, actually.
Yeah, very good. That's what we need to happen.
Yeah. Well, look, thank you so much. We've been going for ages. I just would like to keep you here.
I would like to stay here, but I know probably other people have other things to do, so I guess we should let them go.
We should let them go. So thank you so much, Tamara. It's been an absolute pleasure. Really, really has. And CAM followers, we will see you next week. I can't remember who's on, but there's always something every week. So please do make sure that you tune in. And until then, see you later.
Bye. Thanks for having me. It was fabulous.